Hello, good morning, everyone, and welcome to the first of two webinars in our GBV Innovation Webinar series. As a reminder, we have this first webinar today and another one tomorrow. They're both 45 minutes long. Please be aware that we are recording these webinars with an aim of putting the recordings on our website. So if you or your colleagues couldn't join both the live webinars, then you should be able to access a video recording from the series webpage. This series of webinars is hosted by ELRA and our Humanitarian Innovation Fund, the HIF. The HIF is funded by the UK Foreign, Commonwealth and Development Office and by Norway. Our work on GBV specifically, such as the projects presented in this webinar series, is funded by Norway. With these two webinars, we're showcasing innovations which were awarded follow-up funding last year and whose projects are still ongoing. Through our support to humanitarian innovation, we recognize that the innovation process takes time and that it's not always linear. As such, we're proud that we offer chances for past grantees to apply for funding specifically to work on an innovation that we have previously funded. This opens up opportunities for teams to explore new areas for innovation within their existing work, or to facilitate how others can access the new tools and techniques that have been developed. Today, we'll be hearing from IPAS about the success of their first project with us, adapting the Arches intervention to the humanitarian setting, serving Rohingya refugees in Cox's Bazar. And we'll also hear about how they are making progress, iterating further on the humanitarian application of Arches. With their second project, they aim to increase the scope for the Arches intervention to reach people that are potentially at higher risk and in greater need, the very people who would not ordinarily get to access a health clinic. Before handing over to the IPAS team, I would like to share a few reflections on their work, and more broadly on the importance of humanitarian innovation that addresses GBV. Firstly, we're timing these webinars to be part of the 16 days of activism on GBV. Reproductive coercion, which we'll hear about today, is a form of gender-based violence, where abusive behaviors are used to control a woman or girl's family planning use or pregnancy decisions. Addressing reproductive coercion, as Arches does, is an example of how innovative programming has an important place in humanitarian GBV programs, and how innovation funding can leverage relatively small amounts of funds to give new approaches a chance to increase their scale. We recently published a case study which looks at the adaptation of Arches to the humanitarian setting of the Rohingya refugee camps in Bangladesh. And I want to focus on two of the findings here. First, the value of user-centered design in the process of adaptation and conceptualization. I would stress that adapting from one context to another, or from one delivery method to another, is seldom just a case of translating the language. Second, that through a strong adaptation process, continuous stakeholder engagement, and rigorous evidence gathering, the innovative approach has tapped into other sources of humanitarian funding and is growing in scale in Bangladesh. In this way, it closely aligns to at least two of the 6 tactics that ELRA has identified as common success factors for innovations that are looking to scale through adoption. I do encourage you to refer to the tactics for adoption publication in our scaling series, where you can find other tactics too. In the case of Arches, it has been successfully integrated into existing workflows And in part, through gathering strong evidence, it has moved beyond innovation funding to receive GBV program funding. Now it is my pleasure to hand over to Deepika Paul and Erin Pearson from IPAS. I remind you to use the Q&A function for questions and answers, and we should have some time at the end of the webinar to address those. Over to you.
Thanks so much, Ian. Great. Okay, welcome everyone. We're very happy to be here with you today and sharing about our work with the ARCHES intervention in Bangladesh humanitarian settings. So I'm going to get us started by giving everyone a little bit of an overview. Okay, so as many people on this call I know are familiar, Bangladesh has a very large, almost 1 million forcibly displaced Myanmar nationals are currently in Bangladesh. And we know that, this is a very vulnerable population who've experienced high levels of violence, including sexual assault. We also know from decades of research that there's a little bit of a delay here. Okay. From decades of research that, women in conflict settings are not only experiencing violence, from the conflict itself, but also they're experiencing intimate partner violence or IPV at very high rates. On top of this, we know that women in humanitarian settings also face, large barriers to their reproductive health. So, in terms of managing unwanted pregnancies, in terms of actual prevention, use of family planning and abortion services as well. And part of this, which Ian talked about and mentioned that we'll talk more about today, is reproductive coercion. So we know that, experiences of reproductive coercion, which, as Ian said, is a form of gender-based violence and intimate partner violence, also negatively impact women's reproductive health. It can lead to unintended pregnancies and affects women's ability to control their reproduction. So, on top of this, the uncertain conditions in refugee camps do, limit women's ability to control their reproductive lives. So they're living in these uncertain conditions, but they're also experiencing these, high levels of intimate partner violence and reproductive coercion from husbands, partners, and other family members as well. So it really is important, especially in the humanitarian setting, to be addressing reproductive coercion and IPV to really support women in controlling their reproductive lives. So let's talk a little bit more about what is reproductive coercion. I know this is a term that is probably less familiar to people than terms like intimate partner violence. So when we talk about reproductive coercion or RC, these include behaviors that are by a male partner or a family member, often in-laws, but can be parents as well, that reduce women and girls' reproductive autonomy by interfering with their contraceptive access or use or their pregnancy decisions. So, some different types of reproductive coercion that have been identified include pregnancy coercion. So, pressure or force to get pregnant when she does not want to be. We also know that there's contraceptive sabotage. So, there can be, things like, taking away a woman's contraceptive method, like taking away her oral contraceptive pills or demanding that an IUD is removed. And there's also abortion coercion. So, forced to get an abortion that she does not want. If she wants to keep the pregnancy, she can be forced to get an abortion when she doesn't want to, or she can be prevented from getting an abortion that she wants. So reproductive coercion can look a lot of different ways, but the key here is that it's impacting her ability to control her reproductive life. All right, so ARCHES. So ARCHES stands for Addressing Reproductive Coercion in Health Settings. And the ARCHES approach includes these 3 core elements that you see here in the numbered boxes. And these are approaches that are part of standard family planning counseling. They're delivered by existing staff, either staff who are providing abortions or who are providing contraceptive services. And they're integrated into the standard counseling that's already done and take fairly minimal time to deliver. So the three elements include counseling and screening for reproductive coercion, including talking about methods of family planning that can be used without risk of partner detection or lower risk of partner detection. Counseling on and screening for intimate partner violence, including providing a supportive response to her, providing that kind of intimate partner violence, that first aid, that first validating response, and then supporting her with linkages to other existing intimate partner violence services. And then the third element is provision of this palm-sized booklet. It can be a physical booklet, or in some cases, it's been a digital booklet that reinforces the messages that she's received through the Arches counseling. And through this, women are encouraged to, share this with others as needed, and also use it for referrals for getting others to come into the clinic to receive this type of support. And through these three elements, we see increased quality of family planning care, increased reproductive agency, and decreased intimate partner violence. And today, Deepika is going to be talking about the adaptations of Arches that have been done in the humanitarian setting in Bangladesh. But I also just wanted to mention that this was an intervention that was originally developed for use in the United States and has been adapted in many other settings as well, in Mexico, in Kenya, Nigeria, and for the general population setting in Bangladesh. But Deepika today will talk about the first adaptations that were done for the humanitarian setting in Bangladesh with ELRA funding, which we're so grateful for. So over to you, Deepika.
Thank you, Irene. Good morning, good afternoon, and good evening, everyone. This is Deepika from IPAS Bangladesh. Now I will share with you the adaptation process, what is intervention in humanitarian setting and implementation.
Deepika, I'm finding it really quite hard to hear, so you're going to have to shout, I think.
Is it okay now?
It's just about audible now, but really do try to shout. Let all your neighbors know about this, hopefully.
Hello?
That's sounding better.
Okay, thank you.
Do keep it very close.
Yeah, I need to keep it close, otherwise difficult to hide. Okay, thank you. So I said good evening, good morning, and good afternoon, everyone. This is Deepika from IPAS Bangladesh. Today I will share the adaptation and implementation of Arches intervention in humanitarian setting in Bangladesh. Next, please. Can I move the slides?
It's looking good, Deepika.
Yeah, actually my colleague was telling me that sound is very low, so I was trying to increase the volume. I think now it is okay.
It's clear.
Okay, thank you. I just want to share, already Irina and Ian shared that we adapted the Arches model first for general population and Bangladesh for women who were seeking family planning and abortion service from the NGO facilities in the tertiary level facilities, and then we adapted the Arches intervention for humanitarian setting from the Arches Bangladesh intervention model. And from after successful implementation, it is now scaled up in more facilities with financial support from UNFPA. And currently we are working to adapt the Arches intervention for the community and implementation at the community, especially the women-friendly space and the household level by involving community health workers. Next. Next, please. Let's look at the timeline of our adaptation journey. In 2021, we began with a formative study to understand reproductive coercion and intimate partner violence in the humanitarian setting. In 2022, using a human-centered design or user-centered design approach, we adapted ARCH's intervention for health facilities and implemented in 4 health facilities. In 2023, we scaled up the facility-based model into more facilities based on the learnings from our implementation in 4 health facilities. And from 2024 and onward, we adapted ARCH's intervention for providing at the community, and currently it is being implemented in 3 women's friendly space by midwife and at the housing level by community health workers. Next, please. Next, please. Ian. The next one. Yeah. Now let's explore the facility-based ARCH's intervention implemented between 2021 and 22. We partnered with IOM, BAPSA, and RSTIP for adaptation and implementation of ARCH's. We adopted the ARCH's intervention using user-centered design approach and implemented in 4 NGO facilities near and adjacent to the camp. And primary outcomes included improved self-efficacy in IPV service, reduced acceptance of reproductive question, and increased contraceptive self-efficacy. Next, please. To adapt the ARCHs for use in the health facilities, we followed human-centered design that include, we first did a facility observation and client journey mapping to better understand the experience of women accessing family planning and abortion services. Next, we formed a design team which comprised study team member and community women and girls from the community advisory group, and provided them an orientation on the HCD approach and to ensure everyone was aligned on the process. We then conducted both formal and informal interviews and discussion with the facility staff, providers, clients, and community health workers to gather insight and identify key challenges. To refine the intervention, we held 3 rounds of co-design session where stakeholders worked together to adapt the ARCHES model to be more effective in this context. Next, please.
Should be coming through on the facility-based ARCHES intervention now, Deepika. I'm not sure if there's a lag at your end. Erin, we might need you to step in, as I think we might have lost Deepika entirely.
Okay, absolutely. So Deepika, when you come back, please jump back in. So for the facility-based ARCHES intervention, the key thing here was adapting it from the general population setting in Bangladesh to the humanitarian setting. So, in terms of who was providing ARCHES, it was the health service providers working at health facilities that are either inside or near the camps. They were providing this full ARCHES counseling through their existing one-on-one counseling sessions that they were already doing. And they were using some of the standard ARCHES materials that we adapted as part of this project. So that includes a flip chart that was already being used during counseling. There was a job aid, an information card. And then another piece of this was that there was a guideline for community health workers that was developed to basically help with referrals from the community into the health facilities for women who needed this type of support. And then for IPV referrals with this project, there were great IPV services co-located with the reproductive health services, so they were able to refer on site. So this gives you an overview of what the ARCHES adaptation looked like. I won't go into this in detail for time, but just to give a sense that with abortion care in particular, there are a number of people who are providing counseling throughout, and throughout her service. So there's, there are people who are providing pre-procedure counseling. She's going in for her procedure, and then she's also getting post-procedure counseling where they're talking more about post-abortion family planning use. So this just shows you how the ARCHES elements that you can see in blue were integrated at each stage of that counseling. Okay, and then this gives you an overview of the adapted ARCHES counseling materials. So over on the left at the top, you can see the flip chart. For all of the ARCHES adaptations, we've worked with local artists who do a great job of, of really explaining in pictorial format, what reproductive coercion is. So you can see here, forced basically contraceptive sabotage. He's taking away her contraceptive pills. And then in the other one, he's, preventing her from getting abortion or forcing her to go have an abortion. So, with this adaptation, we found a need to, not only translate things into the Rohingya language, but also to really use, a pictorial representations of reproductive coercion, both on the flip chart, and then also below you can see the information card. And this is, what I talked about before with the palm-sized booklet. This was the information card that she was able to take away with her and share it with others. Okay, so here, this will give you a sense of the results that we had. Because this was the first humanitarian adaptation, we had a short follow-up period. For some of the other studies that we've done, we've had much longer follow-up periods. But for this one, we just did 3 surveys. So there was a baseline survey, an exit survey, and then a 1-month follow-up survey. And because it was a short follow-up, we used, what we think of as these kind of intermediate outcomes in terms of, self-efficacy. So the first outcome that I'm going to share with you is contraceptive self-efficacy in the face of reproductive coercion. And so this is a scale that's been used in various settings, and this is showing you the mean score for women at baseline, at her exit survey. So baseline before she gets her care, exit survey after she gets her care, and then her 1-month follow-up survey. And so what we can see here is that the mean score increases quite a bit from 2.6 at baseline to 4.2 at exit to 4.9 at the 1-month follow-up. And this is a significant increase. Deepika, I just saw you unmute. Do you want to try again? See if we can hear you.
Oh, thank you, Irene. Actually, maybe I was lost, but you can continue this slide and then I can continue again.
Oh, okay, great. So this was a significant increase of about 2 points on the contraceptive self-efficacy scale. So we do see, big increases after the ARCHES counseling, and even additional increases after the service, which is great. So Deepika, why don't I hand over to you to do the next outcome?
You're back. Yeah, that's looking better. Okay, we
Thank
hear
you. Am I clear now? Actually, many of my colleagues reported that they cannot hear me at all. That's why I
hear you well
stopped
now.
and reconnect. I
Much
think now it
better.
is okay. Sorry for that. Okay, let's start. Let me start from the findings on self-efficacy to use IPP support service. Actually, we calculated this self-efficacy by asking only one question: if experiencing violence, how confident are you? You could access the support service. And self-efficacy to use IPP support service increased. We found that it increased from baseline. That was 1.6 at baseline and increased to 1.8 during exit. That is 9% increase from baseline, and 1 point the score increased to 1.9 during 1-month follow-up. That is 17% increase from the baseline. I think you have shared that we did baseline, exit, and 1-month follow-up survey. Before the intervention, we did the baseline, and just after intervention, we did exit and 1-month follow-up. That is 30 days follow-up survey at their household in the camps. Next, please. RC. We also measured, this is another of our primary outcome, attitude about RC, and we also, this attitude about RC measured using a sum score of 11 questions, that is 4-point Likert scale, strongly disagree, agree, disagree, and strongly agree. And attitudes about RC also improved between baseline and exit from a mean score of 10.8 at baseline to 11.9 at exit, that is 12% increase from baseline, and 22.4 at 30 days follow-up, that is 109% increase from baseline. Now I will share the adaptation process and the implementation at the community level. Our objective, after the facility-based intervention, we began adapting arches for the community with additional funding from ELRA, and it is now ongoing process, and it will continue till February 2025. Here we focus to reach women at the community level with arches messages to increase access for women, especially the women who may be experiencing more severe form of violence and are unable to come to the health facilities. And it is being implemented in 3 women-friendly spaces in 2 camps in partnership with Mukti and International Rescue Committee. Next, please. Here, the adaptation process of arches, actually we followed the same process, human-centered design process, to adapt the arches intervention at the community also. Again, we formed a formed 2 community advisory group in 2 camps. In this phase, we are working in 2 camps. And we formed 2 community advisory group in 2 camps because women cannot move from one camp to another camp. And we formed a design team or study team along with the community advisory team members, and again oriented them on the SCD approaches and do the formal and informal interview. This time we did co-design session with the health service providers at the women-friendly space, community health workers, women and girls of the community, and community advisory group members. And again, we did the 3 round of co-design session and adapted the arches model and materials to be implemented in the community. Next, please. At the community, we found that the midwife who is posted in the community, the women-friendly space, midwife provide family planning and abortion services at the WFS. So we identified the midwife can, from our co-design session, it is actually identified from the community that midwife can provide the arches intervention, full arches intervention at the WFS. And community health workers can provide the lighter arches counseling, not the full counseling. That's just basic information about the arches components, and they can refer the women and girls to the either WFS or health facility for full counseling and services. And this can be provided at the women-friendly space where only women are allowed to get inside it and receive services. They come here not only for the services, they come here for taking rest or life skill training and also for passing time. And every day there is some sessions, so they also participate in many sessions. So at WFS, this time at the facility, we provided only one-to-one counseling, but in WFS, it is possible to provide, we identified during co-design session that it is possible to provide one-to-one counseling by midwife as well as group counseling that is held twice per week. And also community health worker who visits households in a month 4 times. And if a community health worker found any women alone at the household, then community health worker can provide the basic information about the arches. That includes the basic information about family planning and abortion services, and where they can get the more information, and how they can screen for whether they are facing the reproductive coercion or intimate partner violence service, and they refer clients to the either WFS or health facilities. And this time as counseling material, in addition to the flip chart and job aid and information card, we also developed a poster that is used during the group counseling with the feedback from the communities and health service providers, and also guideline for community health workers, which include more information about family planning abortion service, as well as information on reproductive coercion and intimate partner violence, and how they can women refer to the clients to the facilities. Next, please. These are the materials for community intervention, or the information card, that is takeaway material which women offered. If they feel safe to take it with them, then they can take it to their household and use for themselves, or share with others if anyone need this type of services. And poster that is newly developed for just group counseling, but we adapted this poster from our Bangladesh adaptation material, and job it for midwives for who provided one-to-one and group counseling at the WFS. Next, please. These are the screenshot of guideline for community health workers. One is for family planning and violence support service, another one for abortion services. Next, please. I already mentioned this. Currently, our implementation and evaluation, we are using pre-post evaluation. This time we did a baseline survey before the intervention and a 2-month follow-up survey at their household. Evaluation is going on and findings are yet to come in February 2025, and we are hopeful to share with you all again. Lessons learned from our community adaptation, we identified that the use of human-centered design approach that enabled us to engage community people, especially the community women, girls, and community health workers, as well as providers. And initially, we did informal discussion with the community leaders also which help us to contextualize urges for humanitarian setting and how we can provided at the household level also, and to increase its effectiveness. And based on our learnings from facility implementation, this humanitarian adaptation has been scaled up to, we implemented in 4 health facilities. Now it is being implemented in 40 health facilities with financial support from UNFP. In the past year, over 43,000 women received urgent counseling from health facilities, including Bangladeshi population. Jan already mentioned that a case study was commissioned by Humanitarian Innovation Fund in October, which focused on the which focused on the evaluation of innovation of urgent intervention. And this case study identified some factors, challenges, and lessons for future improvement in humanitarian settings. The key learnings included urges empowers women and girls to make informed choices and should be integrated into broader programs. Adapting urges outside clinical settings showed its potential to reach more women. Translating materials for Rohingya context revealed challenges, stressing the need for user-centered and culturally sensitive design. And also strong partnership and coordination were crucial for introducing urges in a pediatrical context. Community-based models need continuous learning and adaptation to improve its scalability. Further work is needed to address diverse client needs like adolescents and people with disabilities. And additional time for counseling and comprehension are challenges both for providers and clients to ensure informed decisions. These are the key learnings from the case study. Next slide, please. So thank you everyone for your listening, precious listening. And I am sorry.
No, thank you so much, Deepika and Erin. I'm sure there's a way on Zoom to give a big round of applause. Very well worth it. And we do have, with about 10 minutes, I know that there's been question and answer coming up. A reminder, this is a 45-minute webinar, a flash webinar. I would like to turn briefly to Sarah Cornish-Spencer, who's the chair of our ELRA-HIF GBV technical working group, who has supported us through a lot of this work as well, particularly recently while I've been on parental leave. So, Sarah, do you have any reflections that you'd like to share, or is there a question you'd like to pick up from the Q&A?
Thanks, Ian. Yeah, just a quick word to say how impressed I am with this ongoing work that IPAS is leading. Deepika and Erin, you've highlighted so many things that are inspiring in the integration of reproductive health and GBV programming. I really commend the like how clear the articulation of reproductive coercion is. I think the lens that IPAS is bringing really strengthens reproductive health actors' understanding of IPV, and then also this move to embed the Arches approach within the women and girls safe spaces within GBV programming is also, I think, gonna lend itself to really strong access to services for women and girls at the community level. So I mean, there's just such a lot that's robust about this approach, and really exciting to see it move through the innovation stages and continue to do all this thoughtful adaptation and evaluation work. So I don't have a question. I think I'll leave the ones in the Q&A to the experts to answer. Back to you.
Thank you, Sarah. And Deepika, I'm not sure if you've seen the ones in the Q&A. I know the team's been answering them, some of them as they've gone along. But there's one, I think, about is the host community accessing these services? And I think you touched on that a bit, because as I recall, it's about 25,000 of the counselling sessions have been given to the Rohingya population out of a total of 43,000. So a lot is going towards the host community as well in this heavily affected area. But there's a really strong question here about the issue of backlash, and you mentioned it is a taboo subject. From my understanding of your work, I think the advisory groups that you've had in Bangladesh, the stakeholder consultation has been important, but is there anything else that you'd want to add about how you've dealt with any backlash or the risk of backlash in the community?
Okay, thank you, Ian. Actually, initially we talked with the campaign charts at the community, and first we had to collect approval from the RRC from Cox's Bazar, who gave us permission to work in the community, and we visited the campaign charts in the 2 camps where we are implementing the community intervention, talked with them formally and informally, and get their approval to work in that community. But they did not actually backlash in our work, but they actually approved us to work in that community because this is the problem exists. They also acknowledge that this is the problem exists in the community, so we can work there. But we talked with the community leaders at the community. And also we formed a resource group for implementation, for smooth implementation, which comprise government officials from DG, Director General of Health Services, Director General of Family Planning, partner organization, UN agencies like UNFPA, and all local NGOs who are providing sexual and reproductive health services in the camps, especially in the communities. We incorporated them in our research group, and first we did meetings with them how we can proceed, and with their guidance we actually proceed our work at the community.
Thanks, Deepika. And just picking up on some of the other questions there, I know that we'll be able to share this presentation after the after the webinar. So do keep an eye on your inboxes, as we will reach out to you with the resources that have been shared as well. I know there was a question about what tools are available, and I think Erin, you've answered that one online, is it? But I wonder if you could just voice the answer to that of how people could find out more about Arches or even adopt some of the tools of the intervention.
Right. Great. Thank you for the question. So, as we mentioned, Arches has been adapted in a variety of different settings. So if you want to, reach out to us, to learn more about the different adaptations, because we have some that are for family planning services, some that have been more focused on abortion services. The work that Deepika talked about today was for both types of services. So, we have different, both different service delivery contexts and and also, different cultural contexts that Arches has been adapted for. So, please do reach out to us for specific requests. But I did in the chat put the link to the US version, which is online. So you can see there, those are the only ones so far that have been posted online that are kind of publicly available and ready for public consumption. But please, feel free to look through that. That provides, the set of materials that we have are, provider training manuals and slides, and then also all of the client education materials. So things like, flip charts, the information cards or mini booklets also that clients can take home with them. So happy to share more, but please, I think, reach out to us via email. If you have specific requests, go ahead and take a look at what's online, but then reach out to us, please.
Thank you. And there's another, maybe this will be the final question, but it's, I think, one that could potentially be a whole day of webinar in itself. But how is the framing of reproductive coercion in terms of IPV, as opposed to rights-based or other approaches, made a difference to the uptake or success of Arches? Erin, yeah,
I can start and Deepika can add. So it's an interesting question. I would actually say that the way that Arches has approached this has been both in a lot of ways, because so much of the messaging in the provider training is about, it is very much a rights-based approach. It's very much about, women are the experts on their lives. They're the experts, they have the right to bodily autonomy. They have the right to use, contraception, family planning services, whether or not they have the support of their families. So it is very much rights-based messaging. That is provided. At the same time, it's also a harm reduction intervention. It's not directly impacting, not necessarily, I said in one of the other comments that, we do, as part of Arches, they do offer counseling to male partners and family members. But really the core approach of Arches is providing this, universal counseling, rights-based messaging, both to providers that she is the one who gets to decide, and also to women, that this is a place where you can come and your wishes will be respected. You will be centered as the expert. So it's, I think it's a little bit of both. It's recognizing that this is a form of violence that women are dealing with, but also empowering them with these rights-based messages. Deepika, is there anything that you want to add?
I agree with Irene. You covered actually everything. I just want to share, though we implemented Arches intervention in the humanitarian setting, in the camps clinic, but Bangladeshi population also have access to the these services from that facilities. But in the study, we only included in the Rohingya community population. But Bangladeshi population also, Bangladeshi women also get services from these facilities.
Okay. I think with that, we will wrap up this session. I know it feels harsh to bring the discussion to an end, but as you've seen in the chat, there's plenty of ways in which you can follow up either with ELRA or find more on the ELRA webpage, or with both of our speakers, Erin Pearson and Deepika Paul. I'd like to extend a huge thank you to them. And again, a virtual round of applause. And I'll wrap up as well by reminding people this is part of a little mini series of GBV webinars. We have another one tomorrow in the afternoon in the UK time, in which colleagues from IRC will be talking about their work with developing toolkits so that people can improve or use their data from case management to guide their programs. And I'll say one final thank you as well here, which is to the Foreign and Commonwealth and Development Office of the UK, who support the Humanitarian Innovation Fund, and specifically to Norway, who support our work on GBV innovation. I think we've seen today the role that GBV innovation, or that innovation can play in really helping to improve and find new lenses for looking critically at how we provide support to survivors of GBV and support prevention and risk mitigation as well. Thank you very much, everyone, and do keep an eye on your inboxes, as we will send out more information on the topics that have been discussed today.